Good morning. My topic for today is mood stabilizers. My presentation consists of history, classification, indication, mechanism of actions, various aspects of lithium, various aspects of valproate, monitoring during or before drug administration, dosage chart, and summary. Starting with the history, the effectiveness of lithium of mania for mania and the prophylactic treatment of the maniac depressive disorder was established in the early 1950s as a result of research done by John F. J. Cade, an Australian psychiatrist. Lithium is a monovalent ion, is a member of group 1A alkali metals. Some 300 mg of lithium is contained in 597 mg of lithium carbonate. Most lithium used in the United States is obtained from dry lake mining in Chile and Argentina. Its use increased gradually in 1960s. It was not until 1970 that the FDA approved its labeling for the treatment of for mania. The only other approved FDA indication came in 1974 when it was accepted as maintenance therapy in patients with a history of mania. For several decades, lithium was the only drug approved for both acute and maintenance treatment. It is also used as adjunctive medication in the treatment of major depressive disorder. Sodium valproate was approved for acute mania in 1995. This is a classification along with their chemical structures. Uh, First is the lithium, and then anticonvulsants, valproate, lamotrigine, carbamazepine, oxcarbazine. Well, anticonvulsants and the lithium are considered as first generation mood stabilizers. The second generation consists of antipsychotics. Typical antipsychotics consist of chlorpromazine, haloperidol, and atypical antipsychotic consists of aripiprazole, olanzapine, quetiapine, risperidone, lurasidone. Can other anticonvulsant can be considered as third generation? Well, that depends on their mechanism of action, how much they're effective. Well, it's still a question right now. It consists of gabapentin, topiramate, levetiracetam. Well, indications for mood stabilizers, along with their effectiveness, consists of like valproate is most effective in epilepsy with mania-minded uh, people and depression. In depression, it is a little less effective. We can look at the lamotrigine, where it is much more effective in depression-minded people. In mania also it is effective, but it is a little less effective when treated from above. Carbazepine is also effective in epilepsy, little less effective in mania-minded people, or very less effective in depression-minded people. Well, the last 3-4 drugs like topiramate, zonisamide, gabapentin, pregabalin are much more effective in epilepsy, but very less effective in mania-minded people, and not so effective in depression. Mechanism of action consists of lithium may work by effective signal transduction, but perhaps through its inhibition of secondary messenger enzymes such as inositol monophosphate, known as IMP, by modulation of G proteins, or by interaction at the various sites within downstream signal transduction cascades, including glycogen synthase kinase 3. Well, in an article I had read that lithium helps in modulating the brain-derived neurotropic factors, which helps in neuroplasticity and neuroprotection. In valproate, these work by interfering with the voltage-sensitive sodium channels. We all know the sodium-potassium ATPase. It helps in modulating this, interfering within the sodium channels, enhancing the inhibitory actions of GABA, which is the inhibitory neurotransmitter, and regulating the downstream signal transduction cascades. Although which of these actions may be related to mood stabilization is not clear. Valproate may also interact with other ion channels such as voltage sensitive calcium channels, and also directly block glutamate, which is a stimulatory neurotransmitter. Carbamazepine and oxcarbazine are like sisters and brothers. Carbamazepine acts on inhibiting voltage sensitive sodium channels, stimulating the calcium and potassium channels, modulation of calcium and potassium channels, and stimulating the GABA channels. Oxcarbazine is structurally similar to carbamazepine, not a metabolite of carbamazepine, binds to open sodium channels. Compared to carbamazepine, it is less sedating and less toxic. Lamotrigine may work by blocking the alpha subunit of voltage-sensitive sodium channels and could perhaps also have actions at other ion channels for calcium and potassium. Lamotrigine is also thought to reduce the release of excitatory neurotransmitter, which is glutamate. Coming back to the lithium, therapeutic indications of lithium, bipolar used in bipolar disorder, manic episodes. In manic episodes, lithium controls acute mania, prevents relapse in about 80% of person with bipolar 1 disorder. Lithium has a relatively slow onset of action when used, which is why a benzodiazepine, dopamine receptor antagonist, a serotonin dopamine receptor antagonist, or valproic acid is usually administered for first few weeks. In bipolar depression, lithium is effective in treatment of depression associated with bipolar 1 disorder. Augmentation of lithium therapy with valproic acid or carbamazepine is usually well tolerated with little risk of precipitation of mania. Major depressive disorder. Lithium is effective in long-term treatment of major depression, but is not more effective than antidepressants. The most common role for lithium in major depressive disorder is an adjuvant to the antidepressant used in persons who have failed to respond to the antidepressants alone. About 50 to 60% of the antidepressant non-responders do respond when lithium 300 mg 3 times daily is added to the antidepressant regimen. In schizoaffective disorder and schizophrenia, person with prominent mood symptoms, either bipolar type or depressive type, with schizoaffective disorder are more likely to respond to lithium than those with predominant psychotic symptoms. Lithium is usually used as augmentation agent in schizoaffective disorders with DRAs and SGS. Pharmacological actions of lithium with oral preparation with normal tablets, peak concentration occur within 1 to 1.5 hours. With sustained or controlled release, tablet peak concentration reach in 4 to 4.0 hours. Lithium does not bind to plasma proteins and is excreted to kidneys. Plasma half-life initially is 1.53 days, and 1 year later it is 2.4 days after administration. The blood-brain barrier permits only the slow passage of lithium, which is why a single overdose does not necessarily cause toxicity and why long-term lithium intoxication is slow to resolve. Lithium is excreted in breast milk and in significant amounts in the feces and sweat. Thyroid and renal concentration of lithium are higher than the serum levels. Adverse effects. I had created this mnemonic so that it is easier to learn. It can be learned as a fleet, where A stands for acne, F for floppy infant syndrome, L for lithium in pregnancy is teratogenic, E for ECG changes like T wave flattening, E for Epstein's anomaly, which is a cardiac defect, and T for tremors, which are fine tremors. Lithium toxicity, I continued with the mnemonics. In mild to moderate lithium toxicity, lithium where the lithium level is 1.5 to 2 milliequilibrium per liter. Um, it can be learned as SAND, which is S for slurred speech, A for abdominal pain, N for nystagmus, D for dryness of mouth. In moderate to severe, lithium levels where are 2 to 2.5 milliequivalents per liter. S stands for super, C for coma, A for anorexia, P for persistent nausea and vomiting, and E for EE, which is SCAPE. Continuing with this, in severe lithium intoxication, lithium level which is more than 2.5 milliequivalents per liter, uh, which can be learned as GOD, G for generalized conversions, O for oliguria, and D for death. How it can be managed? First, contact a doctor or go to hospital emergency. Discontinue lithium, measure the vitals, and do neurological examinations. Lithium levels can be checked, serum electrolytes, renal function can be done, and ECG changes can be detected. It check for the MSs and gastric lavage should be done, and absorption with K-exhalate and go lightly. For any patient with a serum level 4.0, hemodialysis can be done. Drug interactions of lithium, co-administration of lithium and carbamazepine, lamotrigine, valproate and clonazepam may increase the lithium concentration and aggravate lithium-induced neurological adverse effects. Most diuretics like thiazide and potassium-sparing diuretics can increase lithium concentration, whereas the osmotic and loop diuretics, carbonic anhydrase inhibitors, and xanthines may reduce the lithium concentration. A wide range of NSAIDs can decrease lithium clearance, thereby increasing lithium concentration. Example, clinically we use naproxen, aspirin, and diclofenac very much. In antipsychotics with lithium, reports of encephalopathy, worsening of extrapyramidal adverse effects, and neuroleptic malignant syndrome. Antidepressants with lithium, reports of serotonin-like syndrome with potent serotonin reuptake inhibitors. Prescribing guidelines for lithium consist of, we already know about the indications. For pre-lithium workup, we can do the thyroid function test. ECG is recommended in patients who have risk factor for or cardiovascular disease. We start with the 400 mg at night to 200 mg in the elderly. Plasma levels after 7 days can be checked, and then 7 days after every dose change until the desired level is reached. 0.4 millimoles per liter may be effective in unipolar depression. 0.6 to 0.1 millimole per liter in bipolar illness, slightly high levels in difficult to treat mania. Blood should be taken 12 hours after the last dose. Take care when prescribing liquid preparation to clearly specify the strength required. Monitoring plasma lithium every 6 months should be checked. More frequent monitoring is necessary in those prescribed interacting drugs, the elderly, and those with the established renal impairment or other relevant physical illness. EGFR and thyroid function tests should be checked for every 6 months. Weight and calcium should also be monitored. Stopping, we can stop these slowly over the at least 1 month, and avoid incremental reduction in any plasma levels of more than 0.2 millimoles per liter. In valproate can be dapakine, dapakot, or valproic acid is approved for the treatment of manic episodes associated with bipolar 1 disorder. It has a rapid onset of action and is well tolerated. It reduces the frequency and intensity of recurrent manic episodes over extended periods. Multiple formulations of valproic acid are marketed. These include valproic acid, which is Davakin, valproic sodium, which is Dapakot, and it is an enteric coated delayed release, which is 1:1 mixture of valproic acid and sodium valproate available in tablet. Can be opened and spread on food too. And valproate sodium valproate injection, which is Dapakon. In pharmacological actions of valproate, valproate is rapidly and completely absorbed 1 to 2 hours after oral administration, with peak concentration occurring 4 to 5 hours after oral administration. The plasma half-life of valproate is 10 to 16 hours. Valproate is highly protein bound. Protein binding becomes saturated at higher dosages, and concentration of therapeutically effective free valproate increase at serum concentration above 50 to 100 μg per milliliter. The unbound portion of valproate is considered to be pharmacologically active and can cross the blood-brain barrier. The extended release preparation produces lower peak concentration, and higher minimum concentration can be given once a day. In uses of valproate, it can be given in bipolar 1 disorder, with acute mania. About two-thirds of person with acute mania respond to valproate. The short-term anti-maniac effects of valproate can be augmented with the addition of lithium, carbamazepine, which is Tegretol, and SDAs or DRAs. Acute bipolar depression, valproate possesses some activity as short-term treatment for depressive episodes in bipolar 1 disorder. In clinical practice, valproate is most often used as an add-on therapy to an antidepressant to prevent the development of mania or rapid cycling. In schizophrenia and schizoaffective disorder, valproate may accelerate response to antipsychotic therapy in patients with schizophrenia or schizoaffective disorder. Valproate alone is generally less effective in schizoaffective disorder than in bipolar 1 disorder. Adverse effects of valproate, again continuing with the mnemonic. Most serious side effects consist of fast with the pH, where stands for pancreatitis, H for hyperammonemia, A for associated with urea cycle disorders, S for somnolence in elderly person, and T for teratogenicity. And the common side effects are weight gain, nausea, and hair loss, and uncommon are vomiting and diarrhea. Coming on to the drug interaction with the valproate, valproate more than doubles when given with lamotrigine, more than doubles the lamotrigine concentration, increasing the risk of severe rash. Uh, Stands for the Steven Johnson syndrome and toxic epidermal necrolysis. With lithium, valproate increases the tremors. With antipsychotics, it increases the sedation, increases EPSs, which is extrapyramidal side effects, and delirium can lead to delirium and stupor too. In clozapine, it decreases the sedation and confusional syndrome. In carbamazepine, it can cause acute psychosis, ataxia, or nausea. It can cause lethargy and may decrease the valproate serum concentrations. Antidepressants with the valproate, amitriptyline and fluoxetine may increase valproate serum concentration. With diazepam, diazepam increases the serum concentration of valproate. In clonazepam, it can cause absent seizures. Uh, in phenytoin, serum concentration is decreased by phenytoin, basically of valproate. Phenobarbital also it increases the serum concentration, in which increase the sedation. And in other CNS depressants, it can increase the sedation too. With anticoagulants, it can potentiate the effect of valproate. Dosage and clinical guidelines of valproate, it can be given in, we have already read that it can be given in mania, hypomania, bipolar depression. For the pre-valproate workup, we can do the LFTs and baseline measurement of any weight, and in prescribing titrate dosing upwards against the response and adverse effects. Loading dose can be used and are generally well tolerated. The controlled release sodium valproate, which is Apellim chrono, can be given once daily. All other formulations must be administered at least twice daily. Plasma levels can be used to assure adequate dosing and treatment compliance. Blood should be taken immediately before the next dose. In monitoring, LFTs and FBC can be clinically indicated, and weight should be measured continuously. Stopping, it can also, like lithium, it can also be reduced gradually over the 1 month. In the mood stabilizers consist of other anticonvergents too, which for that we have done the question mark, which is, can they be considered as third generation? For this, I've added these. Gabapentin, it is mainly used in anxiety disorder, but not primarily in the mood disorders. Gabapentin appears to increase cerebral GABA and may inhibit glutamate synthesis as well. Some bipolars patients have benefited with when gabapentin is used adjunctively with mood stabilizers. Adverse effects are mild, with most common being daytime somnolence, ataxia, and fatigue, which are usually dose related. Gabapentin bioavailability may decrease as much as 20% when administered with antacids. In dosage, generally approach is to start with 300 mg on day 1, increase to 600 mg on day 2, and 900 mg on day 3, and subsequently increase up to 1800 mg per day in divided doses as needed to relieve the symptoms. In final, total daily doses tend to be between 1200 to 2400 mg per day, but occasionally results may be achieved with dosages as low as 200 to 300 mg per day, especially in the elderly person. Coming on to levetiracetam, initially it was developed as nootropic, which is memory enhancing drug. Levetiracetam proved to be a potent anticonvulsant and marketed as treatment for partial seizure. It has been used to treat acute mania and anxiety and to augment antidepressant drug therapy. The CNS effects are not well understood, but it appears to enhance GABA inhibition directly. Levetiracetam is not significantly plasma protein bound and is not metabolized through the hepatic CYP system. The most common side effects of levetiracetam include drowsiness, dizziness, ataxia, diplopia, memory impairment, apathy, and paresthesia. In psychiatry, levetiracetam has been used off-label to treat acute mania. and as an add-on treatment for major depression and as an anti-anxiolytic agent. The drug is available as 250 mg, 500 mg, and 750 mg and 1000 mg tablets, 500 mg extended release tablets, and a 100 mg per ml oral solution and a 100 mg per ml intravenous solution. Well, for the monitoring required with the mood stabilizers, this is a chart for which we can do the monitoring. With the antipsychotics, they can act as mood stabilizers too. So thyroid function test is required everywhere for the initially, and annual checkup is also required. For lithium, we can do it for every 6 months, and in Valproate, continuing with this. At start of in the Valproate, we can start with the at start and periodically during treatment if clinically related. It can done with the carbamazepine at start and periodically during treatment if clinically indicated. With lithium, renal function at the start and every 6 months. More often, if there is evidence or a deterioration of the patient, starts with interacting with taking interacting drugs. We can modulate for the urea and electrolyte at start in the lithium at start and then every 6 months. Full body count can be done only if clinically indicated in lithium at start and at 6 months in Valproate, and similar like in the carbamazepine. In blood glucose, antipsychotics we can at start and then at every 6 months, more often if evidence of elevated levels are seen. Not these cannot be done with lithium, and we don't require it basically. In lipid profile, we can check them in at the start of 3 months and at the 3 months. More often initially if evidence of elevated levels are seen with antipsychotics. These are not required with lithium, valproate, or carbamazepine. In blood pressure, we can do it for the antipsychotics during dosage titration if antipsychotic prescribed as associated with postural hypertension. Similar goes for the prolactin. Uh, Raised prolactin level unlikely with quetiapine or aripiprazole, very occasionally seen with olanzapine, escitalopram, very common with risperidone and FGAs. ECG can also be done if indicated by the history or clinical picture. At start, if there in the antipsychotics, if at start, if there are risk factors for existing CVS, if relevant abnormalities are detected as a minimal recheck after each dose increase. In lithium, at start, if risk factors for existing CVS, similar goes for carbamazepine. For the check of the weight, we can do at start, we can check for it in the antipsychotics and then 3 monthly. And we can check for it if the in lithium, valproate, and carbamazepine, if the patient gradually increases the weight. And for the plasma levels of drug, at least in the lithium, at least 3-4 drugs after initiation, 3-4 days after every dose change until levels are stable. Then every 3 months can be done, and then every 6 months. For in the carbon valproate, titration by effect and tolerability do not routinely measure unless there is evidence of a lack of effectiveness, poor adherence, and in carbamazepine, 2 weeks after initiation, 2 weeks after dosage change. Therefore, do not routinely measure unless there is evidence of lack of effectiveness, poor adherence, or toxicity. In the dosage chart, lithium can be given 400 mg per day, increasing every 3 to 4 days according to plasma levels. At least one study has used 800 mg as a starting dose. In valproate, as semi-sodium, 250 mg 3 times daily, increasing according to tolerability and plasma levels. Slow release semi-sodium valproate may also be effective at 15 to 30 mg per kg, but there is one failed study about this. As sodium valproate slow release 500 mg per day increase as above. Higher so-called loading doses have been used. Oral and intravenous dosages is 20 to 30 mg per kg per day. These doses seem to be well tolerated. Aripiprazole can be used as 15 mg per day, increasing up to 30 mg per day as required. Escitalopram can be used as 500 mg BD increasing to 10 mg BD as required. Cariprazine 3 mg per day increasing up to 12 mg per day as required. Olanzapine 10 mg per day increasing to 15 mg or 20 mg as required. Risperidone can be used as 2 mg or 3 mg per day, increased to 6 mg per day as required. Quetiapine, in initial response, increased response 100 mg per day, increasing to 800 mg as required. Starting doses have been used. In Excel, 300 mg per day, increasing to 600 mg on day 2. Haloperidol can be increased from 500 mg per day, increasing to 15 mg if required. Lorazepam up to 4 mg per day can be used, and clonazepam can be used up to 8 mg per day. Clozapine, established treatment for refractive mania bipolar disorder, is a rapid titration has been reported. In gabapentin, up to 2400 mg per day can be used, probably only effective by virtue of anti-anxiolytic, rarely used, possibly useful as prophylaxis. Lamotrigine can be used up to 200 mg per day. Levetiracetam can be used up to 4000 mg per day. Oxcarbazine can be used up to 300 to 3000 mg per day, and phenytoin can be used up to 300 to 400 mg per day. Topiramate can be used up to 300 mg per day. In pharmacokinetics, uh, lithium has 0 protein binding, and olanzapine has 93 protein binding, and clozapine has 97 protein binding. In metabolism, there are many like biochemical changes can be done, like hydroxylation, oxidation. CYP procedures can be used. Uh, Body uses for these metabolism. Well, summary for consists of comparison of mood stabilizers. Lithium, valproic acid, carbamazepine, oxcarbazine, and lamotrigine, which are the first generation mood stabilizers. Indications are bipolar disorder in everyone, and these are not approved for in youth. And pharmacokinetics, lithium not metabolized, excreted by the kidneys. In valproic acid, glucuronidation can be done, phase 1 and phase 2. Phase 2 is 90%. In carbamazepine, phase 1 CYP3A and 2C19 can be done. Oxcarbazine, minimal P450 interaction, does not auto-induce, more favorable side effect profile. And lamotrigine, glucuronidation can be done in the phase 2. We have already checked for the monitoring levels. Uh, Lithium levels in kidney function, thyroid function, and valproic acid, albumin levels can be checked. Carbamazepine level and albumin level, liver function can be checked. In oxcarbazine, metabolite level, oxcarbazepine, metabolite level, albumin level, liver function. In lamotrigine, no blood work, but important to monitor for skin rashes due to the risk of Stevens-Johnson syndrome. In side effects, I've already told them about previously. In carbamazepine, oxcarbazine, and lamotrigine, cognitive dulling is common, and nystagmus and vertigo, hyponatremia in carbamazepine. Oxcarbazepine, hyponatremia is present, and lamotrigine, only cognitive dulling. In adverse reaction, renal impairment can be seen in lithium. In valproate, pancreatitis, hepatotoxicity can be seen, and in carbamazepine, agranulocytosis is common, and agranulocytosis is also carbazepine. Stevens-Johnson syndrome, as we know, is common with lamotrigine, and toxic epidermal necrolysis. Stevens-Johnson syndrome and toxic epidermal necrolysis can also be seen in oxcarbazine, carbamazepine. In teratogenic effects, lithium we already know, like Epstein's anomaly is very common. Neural tube defects are common in rest of them. In drug-drug interactions, ACE inhibitors, angiotensin 2 receptors, and uh, they are thiazide diuretics. These I have already told. And combination of in valproate, in combination of VP and with lamotrigine can cause Stevens-Johnson syndrome. I have already told about this. There are many drug interactions with CYP interaction, and most with the and in lamotrigine, most particular with the BPA. As a home summary or as a take home, the gold standard treatment for the bipolar disorder is lithium. As for Valproate, in bipolar disorder may be better for those with comorbid substance or traumatic brain injuries. In carbamazepine, in bipolar disorder may be better for those with comorbid substance or substance use, or a negative family history of bipolar disorder. Similar to carbamazepine, which is oxcarbazepine, it has several advantages, including no autoinduction and very much less CYP450 enzyme interaction. In lamotrigine, not useful as an anti-maniac agent and only works for bipolar depression. Well, these are my references, and thank you.